After patients have been treated with gemcitabine-based therapy, typically gemcitabine and nab-paclitaxel, we have to think about second-line therapies. There is a very important regimen that is available. It's called the Nal-IRI regimen. It's nanoparticle liposomal irinotecan, which is combined with infusional 5-FU and leucovorin. Now, this Nal-IRI drug is very intriguing in that it has more favorable pharmacology than irinotecan by itself. What am I speaking of? It's 80,000 molecules are in a liposome, that it circulates throughout the body for up to 1 week. 95% of the irinotecan stays in the liposome, allowing the half-life of irinotecan and its active metabolite, SN38, to increase by 4-fold. Data shows that nanoparticle liposomal irinotecan, there's about a 50-fold higher exposure compared to regular irinotecan, and this translates to about a 5-fold difference in the actual tumor with the liposomal formulation versus the regular irinotecan salt. That then translates into greater activity in preclinical mouse models, which then translates into a survival benefit in a clinical trial called the NAPOLI-1 study. This was a randomized, prospective, global phase 3 study that showed survival of 6.1 months versus 4.2 months, about a 2-month delta in the second line, which is the standard in GI cancers in the second line, the delta of 2 months. And so that has become a regimen that we've accepted in the second line post-gemcitabine use. So what you have then is, and this is according to the National Comprehensive Cancer Network, or NCCN, is the Category 1 recommendation that patients that are given gemcitabine-based therapy in the front line progress or proceed to 5-FU-based therapy in the second line. And that means that you would give a patient gemcitabine nab-paclitaxel. When the tumor progresses or they develop toxicities such as neuropathy or thrombocytopenia, then you would go on to 5-FU-based therapies, that being 5-FU combined with Nal-IRI, showing survival benefit, FDA approved, Category 1 recommendation, and it does not have similar toxicities to the first line regimen. Again, the neuropathy and thrombocytopenia are not observed with the second line therapy. Alternatively, if you were to choose a 5-FU-based therapy, FOLFIRINOX, in the front line, what do you do in the second line? Because the patients typically come off with residual neuropathy. Are you going to use gemcitabine nab-paclitaxel? It's difficult to do due to the neuropathy and also thrombocytopenia that is observed with this first-line regimen. So that's why that first sequence is so attractive and becoming more and more used. Gemcitabine nab-paclitaxel followed by 5-FU Nal-IRI in the second line.